Hi, I'm Dr. Ptacek. I'm going to talk a little bit about one of the specific treatments for opiate addiction, narcotic addiction, prescription pain medicine addiction, and it's called Suboxone. Now, first, historically, drug companies have been trying to come up with a pain medicine that was not addictive, or at least not as addictive as the ones that are currently being used. And they came up with one called buprenorphine. However, it's not absorbed well orally, so when they brought it out as a shot. And it was used in hospitals briefly, but it was more expensive and had some other issues. It'll make sense as we talk more about the drug. So it never really took off. However, addictionologists like myself who were practicing thought this drug might be helpful in treatment of chronic pain in patients who do have addiction problems. For instance, an alcoholic in recovery unfortunately can become addicted to narcotics even when they're prescribed legitimately for back pain, for instance. And it was hoped that this drug, the buprenorphine, might be safer. So some of the smarter addictionologists talked to the pharmacists, and they were able to put it into a troche that would be put under the tongue and then allowed to dissolve. And so addictionologists were using this for some time for pain, specifically in addiction, patients who had addictions. Now, one of the companies then decided that they could get approval for it not to treat pain, but to treat addiction. Since it is less addictive than the Oxycontins and the Lortabs and the other opiates, they thought that perhaps you could use it similar to the way that methadone is used. So it is available, first of all, the buprenorphine by itself, that's called Suboxone, and secondly, it's available as Suboxone, which has the buprenorphine, plus has an additional drug in it called naloxone. Now, naloxone is a drug that is not absorbed well when you put it under the tongue. So when you take a Suboxone, which has buprenorphine and naloxone, put it under your tongue, essentially you absorb the buprenorphine and not the naloxone. Why would they put it there then, you ask? Well, the purpose is that if indeed you decided to heat it up, squish it down, and shoot it into your vein, now in the vein the naloxone is very, very active and the buprenorphine is less so. And so the naloxone would go to your opiate receptors. It would kick off any opiates that were there, such as if you had been using heroin or Oxycontin. It would kick those off and throw you into a very bad withdrawal. So the hope was that by combining the two, it would make the drug even less likely to be abused because people wouldn't want to use it IV. It doesn't work as well as they thought, but that's the basic idea behind it. So now we're going to talk about Suboxone, which again is the combination of buprenorphine and naloxone. The Suboxone, which is the buprenorphine alone, is really used just while you're trying to get people started on the medicine and you're using it in your office. All right, so what's good about Suboxone? Well, number one, there's less rush, less high, less of the feeling, the euphoria that an opiate addict wants when he's trying to be actively used. So if you had an opiate addict who wanted to change his life, wanted to get in recovery, this drug might work for them. Secondly, it does give them normal energy. Again, not the burst of energy that they get after shooting some IV Oxycontin, but a return to normal energy. And if you saw the earlier videos, the lack of energy when someone who's addicted to opiates stops them is a major problem for them. Thirdly, it stops cravings. Remember, that's something that the Vivitrol and Revia did not do. You next can go to your doctor once a month to be prescribed it. So unlike methadone, where you have to go every day initially, the Suboxone, you go to your doctor once a month, you get a month's supply, you take it home. Now, you might say, well, but what if they just use it up faster? And they might. But again, because it doesn't give the buzz or the rush or the high, they are much more likely to be able to take it the way the doctor prescribes it and therefore not run out prematurely. Now, another potential benefit is that if a person gets on a good dose of it, not only does it block cravings and withdrawal and gives them normal energy, but if they were to go out and use a regular opiate such as Lortab, the Suboxone, again the buprenorphine part of it, binds more strongly to the pain receptor than the Lortab. So when the Lortab comes in, the buprenorphine just says, buzz off, we're here first. And so essentially the Lortab does not have any effect. All right, if you do stop it suddenly, remember it is an addictive drug. It's not a non-addictive drug, it's addictive. So if you do stop it suddenly, you would have withdrawal, you are physically dependent upon it. But for all the other reasons that are good about it, it may allow someone with chemical dependence to opiates, or addiction to opiates, to be treated as they have a real disease, which we believe that opiate addiction is a disease. Now, what are the concerns about it? Well, you have to be more highly motivated to successfully take Suboxone because you're responsible for the rest of your program. I will tell you that I want you to go to meetings, whether they be NA or religious recovery meetings or a therapy group where they specialize in helping people who are on Suboxone. But in fact, no one's going to make you go. It will be up to you to do it on your own. So you need more motivation in that regard. Secondly, there either will be no drug screens done at all, or even if I do drug screens on you, you know exactly what day I'm doing them, and they're going to be unobserved. So if you indeed are using other drugs and you want to pull the wool over my eyes, you can bring in someone else's urine who's not on addictive drugs or other addictive drugs, just the buprenorphine, and give me a sample of their urine, and I will not be able to tell the difference. Again, that means you have to be more highly motivated for the Suboxone to succeed. I personally believe that for it to work, you need to work a total recovery program from either Narcotics Anonymous or a religious recovery group. Now, so we decided to make the decision to put you on Suboxone. Well, first of all, starting it is not easy. If, for instance, you took some OxyContin before you left the house, came to my office, and I gave you a dose of the Suboxone, it will throw you into withdrawal. So it has to be a certain amount of time between the last dose and when I treat you. Minimum of 4 hours. The longer the better, quite frankly. And if the opiate that you're using is a long-acting opiate, such as methadone, or if you're using OxyContin but actually swallowing it whole, so you're getting the 12-hour effect, now it takes even a longer period of time before I can safely dose you. Specifically with methadone, it's felt that if you can get your dose down to 40 milligrams or less, you're less likely to have withdrawal symptoms when I first start the Suboxone. Secondly, we'd like to see you go 3, 4, 5 days without taking any. Unfortunately, many opiate addicts can't do that. So one trick that's often used is the week before you come onto a Suboxone clinic is to switch from methadone or any of the longer-acting opiates to short-acting. So switch to Lortab or Percocet or the short-acting OxyContins, and therefore if you stop those, say the night before you come into the clinic, so you take your last dose of Percocet, go to bed, the next morning when you wake up you should be in withdrawal, you come to the clinic and I should be able to start you on Suboxone safely. Now, when I say safely, I'm not going to do anything horrible if I give it to you too soon, but I'm going to make you be dope sick and you're not going to be my best friend for a while. Alright, so we have to pay some attention to what dose of the meds we're on before we go on it, and most specifically how long after the last dose that we take it. We give you the first dose in the clinic, watch you for a period of hours, and then make a decision whether to give you a second dose in the clinic or whether you don't need it. After 2 doses normally, we would feel that we know the safe dose to send you out on, and then you would be given a prescription to take and fill on your own. The appointments are scheduled a month at a time. You certainly can come in early if there's problems, but normally we go a month at a time. Now, so we've put you on the Suboxone, and family members are very concerned because you're still on an addictive opiate, and I understand that. But remember, the goal of treatment such as Suboxone is to get out of addiction, which means get out of the area of loss of control, and get into an area where you can control your use, i.e. you take the Suboxone the way it's prescribed, you keep your appointments with the doctor, you don't steal opiates from other people, you don't buy them on the streets, you're not breaking the law. That's the goal of Suboxone. Now, ultimate goal for everybody, of course, would be to eventually be off of everything addictive. So, what about that? I honestly can't tell you whether that's going to work for you or not. I think that if you go on Suboxone for 3 to 6 months and want to come off right away, you can try that. I think the average person going on Suboxone probably should take it for a year or so, get the rest of their life stabilized, get a good job, get their marriage back on par, become a better mom or dad, you know, get your life on track before you try to change. I think there are people who are going to want to take it long term, for instance 5 years, and I think there are people that are going to take it forever. Only time will tell, but there is no absolute right or wrong. Now, when you do decide that you want to come off Suboxone, again, if you stop cold turkey, you will be dope sick for about a week, just like you would coming off Percocet or Oxycontin. And at the end of the week, when the dope sickness is gone, you will still have cravings. So, first of all, obviously we recommend if you want to come off Suboxone that we do it as a team, wean you off slowly. But more importantly, it means that when you're coming off of it, you have to be doing something else to treat the addiction. As you've seen in the earlier talks, none of the treatments for addiction cure them. A cure is where you have a pneumonia, we give you an antibiotic, you take it for 10 days, and you're cured. A cure is a broken arm that we put in a cast, and God heals it, but over time, we cut the cast off and it's healed. It's now solid as it ever was. Okay, those are cures. Addiction treatment we do not have a cure for, so we have treatments. And so therefore, if you want to get off Suboxone, then you need to either work a Narcotics Anonymous program or a religious recovery program. Again, as you know, I prefer you start that program at the same time you go on Suboxone, in which case 6 months, 1 year, 2 years later, you'll have a good solid recovery program to use to get off. Now, there are some other potential things happening in the Suboxone world. One is, I think we're fairly close to having some rods be released that you would cut the skin and place under the skin, similar to the long-acting birth control pills that women, not birth control, units that women use that last for 3 months, so you don't have to take the pill during the day. Next is, I think we may very well get a once-a-month shot of Suboxone. In that case, it actually would be just the buprenorphine, but we may get a shot that you take once a month, and therefore for a whole month you're not dope sick, you're not craving, you have your normal energy, and you don't have to remember to take it or not. And hopefully it will also block, if you do in a moment of weakness take some other opiate such as Lortab, hopefully it would block that. So that's the kind of the way that Suboxone works, and if you're interested, and I think you should see an addiction specialist and talk about getting put on it. Thank you.